Okay, I'm going to get going. As at least one of you in this room knows, I'm Dr. Rutherford. Just start right off by saying I'm a chiropractic physician. Okay, a lot of people might wonder why chiropractors are involved in doing this, and I'll get into that in just a few minutes. Tonight we're going to talk about peripheral neuropathy, kind of what it is and what it isn't, and some of the new treatments that are out there, and why maybe the medications didn't work. That was kind of our byline in the newspaper. We do a seminar series basically on chronic pain, and peripheral neuropathy is one of the ones that we do quite frequently because it's so poorly misunderstood and there seem to be so few options for it. We're actually videoing this tonight, and so normally I'm going to ask if you wouldn't mind holding any questions until the end. And at the end, I'll stay here until midnight and ask any questions that anybody wants to ask. Okay. If you have personal questions, I'll stay here and answer them. This is Dr. Gates. Dr. Gates is a board-eligible chiropractic neurologist, and he is here on staff. And I'm sure either one of us will be capable to answer pretty much any of the questions that you might have. So it's just rolling. I'm going to get going, but if you could hold questions till the end, that would be really great. So, Dr. Rutherford, peripheral neuropathy. You know, what is it? What is it not? Why are you here? Why do the medications not work? Been doing chronic pain for a long time. What qualifies me? I've been a chiropractor for 30 years, and frankly, I've done a lot of work in the area of chronic pain syndromes. I've done a lot of peripheral neuropathy. I've done a lot of fibromyalgia. I'm not saying I've done it always successfully, but that's how you learn. You get on the bike and you ride. And over the years, it became obvious that there were certain areas that didn't respond to adjustments or didn't respond to therapies. And as I looked more and more, I started to get into areas called functional medicine. And I don't use the term medicine to make myself look like a medical doctor. That's just what they call it. You don't have to be a medical doctor to do functional medicine. So I have a background in something called functional neurology, functional blood chemistry, functional endocrinology. You'll know what that is by the time we're done. And I have a pretty heavy background in nutrition. And more than that, I've treated about 30,000 patients over the last 30 years. And I wrote this book, okay? I'm not here to sell you a book, and I'm not here to tout it. I'm just here to say that the book kind of holds the underlying premises of how chronic pain occurs, how a body works, how it breaks down, and how it can actually get better. Now, my next question would be, how many of you actually think you might be able to get better? It's not many. Okay. Different. Sometimes I get none. It's just like, wow. Okay. Well, that's not normal. Your body is made to get better, believe it or not, and most of you can get well. I said most. I didn't say everybody. Okay, and we're going to discuss why that is. So I guess over the years, and as we've done this, it's become more obvious to me that people don't realize, who have peripheral neuropathy, don't realize that there is any other type of a solution. Okay, or there are treatment options. Basically, the treatment option seems to be, most people seem to think treatment option is take the medication, and then sometimes the medications work, and sometimes the medications don't work. Sometimes the side effects are too much. Or the other option is basically to do nothing, which is kind of what I think a lot of the people in this group seem to think. Okay, and there are more options than that. So fortunately, over the years, there's been tons and tons of data. Some of the data I'm going to discuss with you tonight has been around since like 1973 or longer, but it's just not getting out there. There's a lot of data out there on nutrition as to how nutrition can help peripheral neuropathy, and some of it's very valid. But what we're going to find out tonight and why is nutrition alone is not enough for a lot of you. You're going to find out that one of the most underlooked areas that there is in correcting peripheral neuropathy is the brain. And I don't know how many of you are keeping up with brain therapies that they're having over this decade, but a lot of you have peripheral neuropathy problems that are dysfunctions of your brain, and we're going to talk about that extensively. But even treating the brain alone is not enough, because the brain alone needs a bunch of different things to really work properly. And let me get this myth out of the way, okay? Peripheral neuropathy is not just a diabetic problem, or not only diabetics or MS patients get peripheral neuropathy, although certainly diabetics and MS patients get peripheral neuropathy. There are a lot of different things that cause peripheral neuropathy, lots. More than I'm going to have time to go over tonight, but I'm going to go into a number of them, and I think I'm going to do my best to give you a clear picture of exactly how this works. And so I kind of have my work cut out for me because I'm going to try to do this in the next hour, and I'd really like to have about 6 hours with you, but I don't think most of you would last that long. So I'm going to hang on a second here. No, that's okay.
Excuse me.
No, go right ahead. So let's first define what peripheral neuropathy is, okay? Peripheral neuropathy, peripheral means away from the central, okay? And when we're talking about peripheral neuropathy, this is what we're talking about. Your brain and your spinal cord are the central nervous system, okay? Everything else, and this will pick up, this is the dry part, okay? Everything else outside of the brain is considered peripheral. So the nerves that go to all of your organs are considered peripheral nerves. The nerves that go to your feet, which most of you probably have feet symptoms, are peripheral nerves. The nerves that ultimately later go to your hands are peripheral nerves. So we have peripheral, which means outside of the central nervous system. We have neuro, which means nerves, and we have pathy, which means abnormal, peripheral neuropathy. And we go wrong right there, okay? I mean, that's a very generalized diagnosis. It's peripheral neuropathy, like arthritis, and neuropathy and neuralgia are some of the most misused diagnoses and misused terms out there. They can oftentimes be generalized terms to try to describe something to you that oftentimes the practitioner really doesn't know what you have. And what it does is when you're told you have peripheral neuropathy, a lot of times you think that, oh, I have feet pain, so the problem must be where? In my feet. How many of you think that? Okay. Or you have pain in your hands and you think the problem must be in your hands. Okay. What if I told you that most of the time that's not the case? What if I told you that most of the time the problem is coming from somewhere else? So that's where we go wrong right in the first place, okay? We go wrong by making a diagnosis that makes us think that we have peripheral neuropathy. It's either diabetic, it's either MS, and it's in the hands and it's in the feet, and it's not any of those things, okay? Peripheral neuropathy is not that at all. So that's one of the things we're going to have to break tonight, and we're going to have to get you thinking in a different direction on. The brain basically controls everything, okay? The brain controls all of your organs, it controls all of your nerves, it controls every single thing in your body. If you have a virus come into your system, the brain is the one that tells your cells what cells to send out to tag that virus so that your antibodies can come in and take care of it. So we're going to talk a lot about brain tonight because the brain really is something that we utilize heavily in actually correcting peripheral neuropathy. So what makes the approach to peripheral neuropathy different today that is in the literature is that peripheral neuropathy is today being looked at more as a multi-phased, multifunctional type of a problem. And what do I mean by that? I mean peripheral neuropathy is not one thing, okay? Peripheral neuropathy is God.
Excuse us.
That's okay. That's all right. Peripheral neuropathy is a wide net of different systems that are not functioning normally, primarily the nervous system, but we're also looking at the autoimmune system, We're also looking at your blood sugar system. We're also looking at, we might be looking at your thyroid. We're looking at a variety of different systems that are collapsing upon themselves that ultimately create a dysfunction in your body that's called peripheral neuropathy. And the nice thing about this is it really doesn't matter how long you've had it. It really doesn't matter where you've been. It really doesn't matter if you've tried to take drugs and they didn't work, or it really doesn't matter if you've been to the Mayo Clinic or whatever, because this is not the same model that you have been exposed to. Chronic pain doesn't really respond that well to a medical model. That's why we put out the little tag there that says, what do you do when the medications don't work? Our philosophy here and the new philosophy in treating these types of cases is very simple. The philosophy is treat the person and not the diagnosis. Now, what I mean by that is this. Every single one of you who has peripheral neuropathy diagnosis in here probably is slightly different. We don't use generalized diagnosis. As I said before, generalized diagnosis is very general. A lot of you don't have peripheral neuropathy. They think you have it. I had a gentleman that came all the way down here from Oregon and thought we had peripheral neuropathy. And we cleaned everything else up with him. He felt great, but his feet were still hurting. We ended up adjusting his feet. That's where the chiropractor guy comes in. And his feet were better. And he'd been walking around on bad feet for 20 years, but he was convinced that he had peripheral neuropathy because that's what the VA had told him, okay? So diagnosis is very general. People are misdiagnosed every day. People are diagnosed for peripheral neuropathy, migraines, flus, whatever. What we like to do is we use something called functional diagnosis. You want to get something called that's very specific. How does your body function? What is not functioning in the body? You want to look at the different parts of the body, see which parts of the body are not functioning, and find out which of those parts of the body could be causing the symptom that you have that's probably not in your feet, or the problem's probably not in your feet, except for the guy who came down here from Oregon, and the problem actually was in his feet, and it wasn't peripheral neuropathy. It was actually just a mechanical problem that he was a landscaper and he was beating up his feet forever. All right, so we look at more specific diagnosis. When we look at, you tell me you got peripheral neuropathy, what does that mean? It really doesn't tell me anything. There can be like 500 different things that can be combining to cause the types of symptoms that you're having. So I might look at you and say you have something called a Th1 dominant autoimmune attack. And that Th1 dominant autoimmune attack is actually creating a situation in which your immune system is attacking and literally damaging your nerves. We might look at you and say you have a phase 7 adrenal exhaustion, stage 7 adrenal exhaustion. And a stage 7 adrenal exhaustion is going to mess up your blood sugar. It's going to cause a lot of inflammation, and it can damage nerves in certain areas of the body, your toes, your feet, and so on and so forth. And that can cause peripheral neuropathy. We might look at you and say you have a parietal lobe problem, okay? And I'm going to explain what that is in a second. We might say you have a brain dysfunction problem with your parietal lobe, and your brain's not firing properly, and your brain isn't firing off to certain parts of the body where it should be, and that might be what's causing your peripheral neuropathy. I've had people come in who've had overloaded iron causing their peripheral neuropathy. We've had people come in here who've had a variety of different autoimmune thyroids and autoimmune pancreases and so on and so forth that'll cause your peripheral neuropathy. I'm going to explain all of this. But what I'm trying to say is it's not one thing. It's not one thing. If we find out that you have a parietal lobe problem in the brain that's causing your peripheral neuropathy, well, guess what? There's something that can be done about that, and we're going to explain that. This is functional medicine. You find out what's not working, and if it looks like that can be causing the numbness and the tingling and the pain and the cramping and the burning that you're having, that's what you treat. And it works, okay? So if we have a parietal lobe problem, there's a lot of things we can do about that. We can rehabilitate it. Parietal lobe is a part of your brain. We're going to talk about it a little bit more later, because a lot of you have this part of your brain that's not firing right, okay? And so parietal lobe is a part of your brain. You can actually strengthen it. You can actually take the neurons of the brain, strengthen it, rehabilitate it, and bring it back to normal so that the pain goes away. And I want you to start thinking of your brain, because we're going to talk a lot about the brain in the next hour. I want you to start thinking of your brain as a bunch of different muscles, and just different groups of muscles that do different things. And some of them are sensory, some of them feel, some of them make things move, some of them are good for gross movements, some of them are good for little movements. Every single thing you do has to do with your brain. And feeling to both of your feet has a specific part in the brain that does that. And that's in the parietal lobe, okay? So start thinking of your brain as muscles, because if you think of them as muscles, we're going to be able to get through this a lot easier. And if you have a weak muscle, what happens? You have a weak muscle, that right here, that arm starts not to work very well, okay? If you have a weak part of your brain, the part that it's supplying in your body starts to not work very well. So you can strengthen it, you can rehabilitate it. There's a variety of activations that you can do that will actually bring these muscles and these parts of your brain back to normal. And for some people, it's surprising how quickly that can occur. If you have a Th1/2 dominant attack and it's causing an autoimmune problem, or if you have blood sugar problems, or if you have any of those can be evaluated, and we can find out what you have, and we can look at that, and you can balance those out nutritionally. So the way that you look at this is you look at the case, you look at the individual, you look at what's going on, and you take each individual spot, each individual area, and you strengthen it, you rehabilitate it. Now, the latest research that's out there, and it's new. A lot of the latest research is just in the last 10 years, shows that one of the biggest problems that people have who have a peripheral neuropathy case is something called a functional disconnection syndrome. And it's a functional disconnection syndrome. It's something that's in your brain. Now, we don't just do peripheral neuropathy. We do fibromyalgia. We do a lot of thyroid problems, because that's involved with we do a lot of kids. We do a lot of ADD, ADHD. We do, believe it or not, I don't know why it's become so controversial all of a sudden, we do autism. And all of these are different variations of something called a functional disconnection syndrome. And so is peripheral neuropathy, okay? A functional disconnection syndrome is this, all right? We have two parts to the brain. We have two parts to our brain. What's unique about the human brain is this, and this is important for you to get. You may not know this, because we are the only animals, if you will, human beings on the planet, that have a brain that has two different sides to it. We all know we have two sides, right? Most of us know that the right side kind of sort of does the left, and the left side kind of sort of does the right, okay? The right side is totally different from the left side. Right side of the brain is kind of, it's a generalized brain. It's more of your artistic brain. Your right brain is the brain that in the beginning of when we're starting to learn how to walk, teaches us how to walk. It learns gross movements. It's your sad brain. It's a brain that when you get sad, it's your right brain that gets sad. I'm not going to go in like the hundreds of different things, but the left brain is just the opposite of that. The left brain likes fine motor movement. The right brain the right brain will look at you, and it can kind of see if you're visual, as far as like communication goes. You can look at somebody and kind of visually think, oh, that person looks like maybe they don't like me or something. That type of communication. The left side of the brain does specific communication. Actually, the words that are coming out of my mouth are coming from the left side of the brain. So, and it's your happy brain. The left side is your happy brain. My right side is kind of your sad brain. Well, the point I'm trying to make is we have two different brains that have to coordinate. Okay, no other animal on the planet has that, none. So our brains have to coordinate. From the time we're born, it has to be coordinate, there has to be timing, everything has to develop correctly for us to be a normal functioning human being. At some point in time, that coordination will get thrown off. There's a variety of reasons that can happen. And we're going to talk about most of the major ones by the time we're done. But the latest research shows that a functional disconnection syndrome is probably involved in probably 60 to 70% of the peripheral neuropathy cases. And a functional disconnection means these two brains are not coordinating, okay? The two sides of the brain are not coordinating. It's an electrical imbalance. It's not a chemical imbalance, and what happens is the two sides have the electrical wiring there, okay? But the electrical wiring just isn't working right. And so one side starts to dominate the other side. And the firing of the brain isn't exactly the same on both sides. It's kind of like a marching band. It's kind of like if you have two lines of a marching band, they're supposed to be in sync. They're supposed to be playing at the same tone level. They're supposed to be playing at the same beat. And then all of a sudden, one guy decides to, instead of playing like the Saints Go Marching In, he's playing like Harry Belafonte, you know? And all of a sudden it's like, or Al Hirt, I guess he was a trumpet player. And all of a sudden, what happens? They can't coordinate. These two sides of the brain cannot function normally together. And what's going to happen is you're going to get kind of a scratchy noise, and it's not going to be much of a marching band. That's what's happening in a lot of chronic pain patient brains. And that's what's happening in probably, of those of you who actually have peripheral neuropathy, that's what's probably happening in about 50, 60, 70% of your cases. All right? And it's happening in the parietal lobe. Now, this is a well-known phenomena. It's widely researched, but for some reason it's not out there today in the common medical model. Okay? I think it's because there's not a drug that can fix it. And I'm not being facetious. I'm not an anti-medical doctor. Let me put that out there right now. But this is what a lot of the new research shows. So when that stops functioning normally and it goes off in a fibromyalgia patient, you might get, and I know I'm peripheral neuropathy here, but in a fibromyalgia patient, you might get brain fog, you might get inability to grasp your words, you might get GERD, because it affects some other muscles in the abdomen. You might get chronic pain of diarrhea, and you might get constipation, diarrhea, and you get that pain all over the place. In a peripheral neuropathy patient, it affects one part of the brain more than it does in a fibromyalgia patient. And if it affects your right parietal lobe, which we're going to talk about in a second, you're going to find out that you could get numbness and tingling and burning in both of your feet. And later, you could get it in your hands. And frankly, you can get in, you could eventually get in a lot of other places. So that's part of what the latest research shows. Now, the latest research also shows that autoimmune problems are a huge part of the peripheral neuropathy clinical profile. Okay. Now, what do I mean by autoimmune? I don't have enough time to really go into that relative to a late class, but an autoimmune problem basically means that your immune system has started to attack itself. And it's not uncommon. It used to be thought to be very uncommon, but it's very common today. And in autoimmune patients who have, in autoimmune patients who are peripheral neuropathy, there are a lot of different organs that can be attacked. It could be your pancreas. So people are thinking you're diabetic, but actually you're not. You have an autoimmune problem. It could be your thyroid. It could be your liver. We see a lot of autoimmune thyroids that are causing people who have peripheral neuropathy symptoms. So we could have the brain, or we could have an autoimmune attack. And you have to use you have to use specific diagnosis. You can't just say, oh, you got peripheral neuropathy, because what does that tell us? It tells us really nothing. So a lot of you are going to have autoimmune attacks. What the autoimmune attack does is it actually will, it's a very bad dysfunction, and it actually will start to turn your immune system on so that it starts to attack, in your particular case, your nervous system. Not everybody, not all of you here, but certainly many of you. And when it starts to attack the immune system, it starts to attack the outside of the nerves. You have a nerve that is, you have the nerve, as we're looking at it on end, here's the nerve, and here's the fat around the nerve. It's called the myelin, okay? Fatty myelin around the nerves. And it attacks this, okay? And it literally breaks it down. And it'll break your nerves down, and it'll start to give you all of the symptoms of peripheral neuropathy. And it can be caused by a virus infection. It can be caused by diabetic insulin responses. Every time you have a blood sugar response, you can have an inflammatory response. It can be caused by insulin resistance. Does anybody here know what insulin resistance is? Okay, it can be caused by that. I'm going to talk. That's pre-diabetes. Okay, it can be caused by toxins. It can be caused by a lot of different things. And what happens is at some point, your system becomes sensitized to some foreign object, and then your immune system starts to mistake your body for that foreign object. And once that happens, it turns on your genetic code, and there's nothing that can be done to change it. It can be fired down. It can be quenched down. But it's something that you'll have forever. But it's something that you need to look for. Another thing, while I'm talking about it, that the latest research shows is certainly that blood sugar issues can be involved with this, okay? But we're mostly usually thinking about diabetics. And you don't have to be diabetic to have your blood sugar messing up your blood sugar enough to create an inflammatory process that's going to literally damage your nerves. So a lot of people have what's called low blood sugar. A lot of people have what's called insulin resistance, and you go to the doctor, and the doctor says, well, you know, you're okay, don't worry about it, and we'll wait until you get to be a diabetic. A lot of you have that problem, and a lot of you are having your nervous systems irritated by inflammatory insulin responses, okay? And so, or you could have all three of them. Now, I'm going to tell you, there's like 500 different things that could involve this. I've had people who've come in here who've had hematochromatosis and didn't know it. That's too much iron in your system. And that turned out to be what was causing their peripheral neuropathy, okay? And we've had people who've come in here with all different types of anemias and different types of blood problems and so on and so forth. So it's not one particular situation. It's all of these situations put together. And let me just go back to the blood sugar. Like I said, a lot of you, how many of you think you got blood sugar problems here? All right, I'm going to tell you, like 5 people raise their hand. I'm going to tell you, like, that's impossible in this room. Probably 80% of you have either low blood sugar or high blood sugar, probably not diabetes. And I'm going to tell you why you don't know that. Because you probably are thinking, well, I don't have thyroid problems, I don't have blood sugar problems, I don't have it, because I went and I got my blood tests done, and the blood tests were normal, right? But the blood tests aren't normal. None of the peripheral neuropathy sufferers in this room have normal blood tests. None of you. I can tell you, because I've been doing this for a while. You're all going to have some of what we just got done talking about and more, or maybe even combinations of it. It's not unusual for us to find autoimmune cases combined with different types of blood sugar cases. And what happens is you go to a lab, and you go to the lab and you go get your blood taken, okay? The way that they're doing blood tests today, honestly, is still like from the 50s. It's not done right. Now, if any of you work here in hospitals, by the time I get done, you're going to be shaking your head up and down at what I say. Because what happens is you go to a lab, okay? And basically the lab takes all of the blood of all the people who've been going there for 5, 10, 15, 20 years. And they feed it into a computer, and they do something called a bell curve analysis, okay? So you're sick. You're a sick person going into the lab, okay? And we're cataloging what's normal by all the sick people who've been going into this lab forever. And as more and more people, so what they do is they do a bell curve analysis of all of the iron markers. And then they say, this is our blood sugar, let's say blood sugar. And they say, this is what's in our lab. We'll cut off the highs, we'll cut off the lows. This is the norm. If anybody had a lot of lab work done, you'll notice that when you go from different labs to different labs, that the norms are different, that they're different. Or I'll get something, I got one last week and said, as of this date, the new normal for this is going to be this, okay? How can that be? It's because you keep getting more and more people coming into that area, into that lab. The markers keep getting wider and wider and wider and wider, and what used to be normal is now normal. So we're missing an awful lot of people who are sick by looking at these lab markers. So you can't, and the other thing about reading blood tests is this, okay? And this is important to you because this is part of the reason your diagnoses are being missed. The other part is that you can't just look at one blood marker. We had a gentleman who came in here with peripheral neuropathy not long ago. We just dismissed him, okay? Not only did he have peripheral neuropathy, he couldn't sleep, he couldn't do anything like that, and he had low blood iron. So they were giving him iron. But when we did the full panel of tests, he had something called a high ferritin level. Now, a lot of times you're not going to get all the tests because they're not considered medically necessary. In other words, he had too little iron in his blood, but he actually had too much iron in his cells, and it was killing him. People who have that don't have a long lifespan. They also tend to get peripheral neuropathy diagnoses, okay? Anyway, he couldn't sleep, he couldn't do anything. We had to have him go dump blood. He was taking iron because not enough markers were being taken to read the patterns. So you're supposed to read blood patterns. You're not supposed to just take one marker and read one marker. But because of today's economy and because of today's medical necessity and the limitations of the insurance industry, you're not really getting full blood panels like used to be done years and years and years ago, and they're being read too widely. So we use something called functional blood chemistry analysis, and the functional blood chemistry analysis put out by the National Chemistry Group that does these things for the labs all over the world. And their functional norms, what they use to look at you, are based on what healthy people should look like. So our norms are much less forgiving when we look at them. We pick up a lot of things that you probably don't think that you have. Most of you, it's almost impossible to be living in this country for as long as most of you have been living and not have some sort of a blood sugar problem, unless you've been very, very attentive to your diets. It's just, you know, because you're eating the standard American diet, and we see it all the time. So that's what you're looking at. That's kind of where you're at, and that's kind of how you got here. We do functional blood chemistry analysis. We do functional neurology. In other words, when we get any chronic pain patient in here, the brain controls everything. Somewhere around in the early 1970s, somebody went like, God, if the brain controls everything, maybe these chronic pain syndromes are actually coming from the brain. And indeed, most of them are. Okay, so we are back to, and I'm going to explain this more in a second. So we have a background here in functional neurology. I have a background in functional blood chemistry and functional endocrinology. And that's what you have to have, and nutrition. And you have to look at all of the parts of your body, because this is like Eastern medicine made Western. I don't know how many of you, are familiar with Eastern medicine, but you're looking at the body, and the body has to be what? It has to be in balance. Those of you who are here, your bodies are out of balance. You have 9 systems in your body, and those 9 systems are not calibrating. They're not balancing. And I just only use 3 or 4 examples to show you how many different systems that are out of balance that can cause the same symptom when we used the generalized diagnosis of, in your case, peripheral neuropathy. Okay, so that's why we look at it all. We look at all of you have to look at all the symptoms at all the systems at once, and that's what the latest research shows. It doesn't really fit the medical model very well, because this is kind of it's not considered medically necessary. Nobody's going to look at you like that. Frankly, that's the way we look at our patients, and that's the way you have to do it. It's very labor intensive, and that's what has to be done. So let's look a little bit at this brain. Let's look a little bit more at this brain. I'm going to try to really give you, I'm hoping that by the time you walk out here in the next, say, 30 minutes or so, you really understand what peripheral neuropathy is. That was kind of like the lead up, okay? You've heard me mention this brain part called the parietal lobe, okay? So now I'm not much of an artist, as you've already figured out, okay? So this is your head. And I'm going to draw it in half. I'm going to say this is the right side of your brain, as though we're looking at the person. And this is the left side, okay? And this would be the parietal lobe. There are 2. Parietal lobe. Okay, there are 2. There's a left and there's a right. Okay? And each parietal lobe looks like this. There's actually a map of all of the parts of the body on the parietal lobe. The parietal lobe does a bunch of different things. It senses all of your joints. It senses all of your muscles. It helps you to make gross movements. It is very important to the peripheral neuropathy patient to understand this. Now, I don't know how well you can see this, but there is a map that lays on the brain like this that corresponds to the nerve cells that when you think, I'm going to move my toe, okay, this is where the thought comes from, and then it goes down and it moves your toe. Now, you'll notice that the hand and the mouth and the face are huge. They have a lot of nerve supply that are contributing to them. Okay? Why? Because we use them. Because we're using our hands, and I'm using my hands and my face right now. Notice how small your toes are, and your feet, and a lot of you have low back. I've been doing chiropractic forever, okay? A lot of you have, see how small your low back is? How small the amount of nerve supply goes to that? One of the reasons we have a lot of low back problems. One of many reasons, but definitely one of the reasons. But look at the toes. So if we have a dysfunction in this area, what's going to bother you first? The hands or the toes? You're probably looking at the feet going first. Most of you have peripheral neuropathy in your hands and your feet. It started in your feet first. Yeah, and this is why, okay? So what happens is we get that functional disconnection syndrome that I talked about, where a couple of sides, two sides of the brain start not functioning right. And this part of the brain comes down, and it goes down to the other side. All right, told you I'm not much of an artist here. All right. And it goes down to the other side, like that, and this side, when it's not functioning, goes down to this side. But here's the catch to the right-left thing. The right parietal lobe has a map of both sides of the body. So if you have a right parietal lobe problem, which a lot of you do, and if these muscles are not functioning well, remember I said try to think of this as weak and strong muscles? So if these are weak muscles on this side, guess what's going to happen? You're actually going to feel pain, numbness, tingling, cramping, and burning in both feet, because the right parietal lobe controls both sides. Now it's funny because the left parietal lobe only controls the right side. It's kind of an anomaly, but that's just the way it works, okay? You can check me out on this. It's in any neurology book. So we have the parietal lobe, and that's the way it works. And the parietal lobe is something, it's kind of a map. It tells you where you are. And one of the things we do when we're trying to strengthen some of the nerves is we have people point to things as to where things are, because that's the where part of your brain. Okay, it tells you where you are, and it tells you, and it controls a lot of gross movements and so on and so forth. So the parietal lobe is a very, very, very involved part of what's happening. Now, why does the parietal lobe stop functioning? Tons of things. Okay. Tons of things. I mean, it could have been an infection. It could have been that you took a knock in the head. It could have been that you had a serious stress at some point in your life. There's a bunch of things that could cause it, but what happens is you end up getting this functional disconnection syndrome. The one side of your brain starts firing not as well as the other side of your brain starts firing, and the next thing you know, you have a situation in which the parietal lobe on one side or the other is weak. You start getting symptoms in your toes. Most of the time it'll start from your toes, it'll go back to your feet, and then the next thing you know, after it usually gets up to here, then later, usually a couple of years later or whatever, it starts in your hands. That is one thing, that is one part of what could be happening, but it is a major part of what is happening with probably about 70% of you. All right, how do we know this? This is what we do. So, and this is actually, and this is actually the way it is. So I'm not going to go into all the different patterns, but I want you to understand the major one that is involved in your particular type of situation. Now, the brain is kind of an interesting thing, okay? The brain needs two things to operate. It needs fuel, and it needs activation. Like you've heard, don't use it, you lose it. Okay, never was there anything more true than your brain. I mean, you really want to keep pushing your brain from now until forever, because as you use your brain and use your brain and use your brain, it's even more important than doing exercise for your arms, because it actually builds new neurons. It does a bunch of different stuff, which I want to talk about here. Your brain needs fuel, and it needs activation. Most people, let's talk first about the fuel, okay? Let's talk about the fuel. There's two fuel sources that the nerve cell in the brain needs. It needs sugar, needs glucose, okay? Notice we keep talking about sugar, and it needs oxygen, all right? Let's talk about glucose first. Glucose is something that none of us have very much trouble getting into our bodies. In fact, most of us overutilize glucose in this country. All right? And what happens is we usually start out as having normal blood sugar as children. Then we start eating things that aren't all that great for us, and the candies and the this and the sodas and the white breads and all this great stuff. And eventually what happens is our blood sugar starts going low. What happens is you're putting out too much insulin to try to manage the blood sugar. The blood sugar hits the cell opens up, the blood sugar goes in there, and it drops in your blood. So it's in the cell, but it's not in your blood. That's low blood sugar. And a lot of you probably have that and don't even know it. If any of you get irritable and shaky and grumpy and irritable and then you eat and you feel better, you got low blood sugar. I don't care what your blood sugar, I don't care what your blood tests say, you have low blood sugar. The next thing that happens is the cell starts becoming resistant to the insulin that's trying to get it in there. Everybody, you've heard of insulin resistance. Anybody else has ever heard of it? That's what this is, okay? So insulin resistance is the cell becomes resistant. Now the blood sugar stays in the blood, and you have high blood sugar, and you're considered insulin resistant or pre-diabetic, or okay. Now I'm going to tell you something. If you're in that area, you're diabetic. They won't tell you you're diabetic, but you have the symptoms of diabetes, and that blood sugar mechanism, every time your blood sugar goes up and down and spikes, every time you get irritable and shaky and you have to eat food, or every time you eat food and you crash afterwards. Anybody here eat food and crash afterwards? If you do, you're insulin resistant, okay? Every time that happens, you're creating an inflammatory response, and that inflammatory response goes it goes from your gut, and the first place stop it makes is in your brain, and it inflames the brain. And if your brain is off, and your brain is not firing correctly, and it's not getting the proper fuel, it continues to exacerbate the imbalance that's in your brain. So you need glucose. Glucose does a ton of things. If you're inflaming it and you happen to have an autoimmune problem, it inflames your autoimmune problem. It causes mood swings. A lot of people who come in here who have depression and anxiety and panic attacks and stuff, it's adrenal glands and blood sugar most of the time. And we see it all the time. We don't treat people for that, but we're treating them for the other thing, and all that goes away. Treat for the peripheral neuropathy, get the blood sugar right. And I'm trying to draw a picture of how it all goes together, okay? How it's not one thing. And so we have the blood sugar. We have so you need the blood sugar, and you need oxygen, okay? Oxygen, all of us start utilizing our ability to use oxygen on a cellular level by 1% a year after the age of 25. So if you're 50, you've lost about 30% of your ability to utilize oxygen. Exercise is good and a number of things are good, but what happens is there's just an all-out attack. There's infections, there's inflammations, there's junk that we eat, there's a lot of stuff. Your brain is so dependent on oxygen. 40% of the brain of the oxygen that goes in your body goes to your cerebellum, which then ultimately goes to your brain. So those of you who smoke, those of you, and stuff like that, you're decreasing your oxygen levels by about another 40%, and you're killing most of the nutrients that go in your body. I mentioned that for a reason, and I'll tell you what that is in a few minutes. I'm not trying to make anybody upset if they smoke or anything like that, but it makes it a lot harder to do the types of things that you would need to do to get rid of what you have. So the brain needs fuel and the brain needs oxygen. If you have anemias, guess what? It's really hard to get a peripheral neuropathy patient better if a peripheral neuropathy patient has anemia, because you're already not getting enough blood, not getting enough oxygen to your cell, and now you're getting even less oxygen to your cell if you have an anemia. So I have a lot of patients come and go, yeah, I've been anemic, but the doc just said, you've been anemic for a long time, just leave it that way. Whew. I don't think so. We're just talking like lack of oxygen to every cell in your body. You don't have enough energy. Even if you wanted to try the vitamins and the supplements that you read about, they're not going to work very well because your cell's not going to make enough energy to use them. And your brain's certainly not going to get enough oxygen. Your brain needs oxygen, and your brain needs glucose. Your brain also needs activation, okay? And there are a lot of different ways to activate your brain, and I'm going to talk about that in a minute. But let me just stop now. And I'm actually trying a little bit of a new talk here tonight because I want to try to draw a little bit more practical picture for those of you who have taken the time and effort to come out here as to why when you take one medication it doesn't work. What are the common treatments for what you have? Okay, common treatments are the medications, okay, and I can go over all the different medications, but it's basically all the same. For some of you, they work, and I know a lot of you are in miserable pain. I mean, if it cuts the pain, good for you. And I mean, and I'm not telling you to not take your medications. However, I will say I've never known a case where a medication has ever fixed a peripheral neuropathy case, okay? I've seen cases where supplementation has fixed a peripheral neuropathy case because that happens to be the one part of this whole picture that was the problem with that person. All right, but the supplementation balances out systems. What the medication does is the medication goes in, it either makes things, in your case, usually the medication depresses the system. Usually it depresses the brain. And so it's either going to help you, it's not going to help you at all, it's going to help you and there's going to be a lot of different side effects. And so, but medications also bind up things called receptor sites. So a lot of you might have had the experience of taking a medication. It worked for 6 months, and then it stopped working, or it started working less. And that's just the common mechanism of how medications work. They go in, they go to the cell, they bind on what's called the receptor site in the cell. There's only so many receptor sites. Eventually, the medication can't make that effect anymore, and it stops working. Then you go to the next medication, which is a different mechanism. They'll go from one mechanism to the next mechanism, and then that one won't work. Second choice option, I think, for you folks is do nothing. I mean, that's what a lot of the doctors tell you because they say there's nothing that can be done for this. And they generally don't know that there is anything else that can be done for you. Okay? If it's not a medicine, if it's not a pill, or if it's not a surgery, it's just not taught in that medical model. And hopefully you're beginning to see why the medical model can't work for chronic pain. Because one pill isn't going to be able to determine and or correct all of the different potential areas that could be going wrong that could be causing your specific symptom that is being called peripheral neuropathy. And then the third option today, I think, is they're actually doing surgeries today. I don't know, has anybody here had one of those tarsal tunnel releases or anything like that, or been offered one? That you had it? You've had it done? Okay. So, so I won't go into all the ramifications of that, but they're not generally very successful overall. And their model of success is measured in kind of an odd way. But they go in, they decompress the area, they decompress the nerve, and they do that without knowing or having investigated all of these other different areas that could have been causing the pain in the feet. Remember in the beginning when I said we first go wrong, and I say because the pain, right where we go wrong is we think the pain is, we think the problem is where the pain is, okay? So that's why the medical model is great for acute pain. It's great for emergency care, but it's not really good for most chronic pain syndromes. So what you have to do is you have to get the brain working. You have to figure out what things might be driving it. And I'm going to go back to the brain for a second here. We need fuel. We need oxygen, and we need activation. Why do we need activation? We need activation because you don't use it, you lose it. You don't activate your muscles, they go away. But here's the thing with the brain, okay? This functional disconnection syndrome that we talked about, remember this, all right? The functional disconnection syndrome is going to make one part of the brain depressed, and it's going to make the other part of the brain more. So let's just say let's say something happens. You have two sides of the brain. They're completely different because we're human beings that have this odd brain that needs to be two sides and needs to be synchronized, and it needs to be like this. Something happens. One side goes down, okay? A lot of depression. A lot of depression is right frontal lobe. A lot of depression is left frontal lobe in ladies. And there's a lot to do, not that ladies have weaker left frontal lobes, all right? It just, there's one side that favors the man more so than the lady. And what will happen is your happy brain will start to depress. When your happy brain starts to depress, what's going to happen to the other side that's supposed to be in balance? The other side is actually going to function more. So your sad brain is going to function more, and it's actually going to dominate and become a bully at some point in time. And as time goes on, usually most of your patients that come in for these things are getting worse and worse and worse because the balance is not there, okay? And I use that because it's just a little bit more of an understandable example. But that's what happens in peripheral neuropathy. And peripheral neuropathy, most people, the right parietal lobe or the right brain goes like this. So if we do a medication and we have a brain that's dysfunctional and it's not working on either side properly, is a medication which is going to depress it and it's going to make you feel better. Is that going to fix anything? Can it fix anything? It can depress it, it can make you feel better, but it's not going to fix this imbalance in between the two sides of the brain. It can't. All right? Physical therapy is not going to help it. Chiropractic manipulation is not going to help it, you know, unless we do it right, unless we do it on one side. And so anyway, so that's what happens. And so you have a dysfunctional brain, and you need to activate the weak side of the brain. Remember, the weak muscles. I said try to remember to think of the brain as muscles. This side of the brain is going to have weak muscles. You need to activate and strengthen this side of the brain to get it to go back like this. And when both sides of the brain begin to synchronize and when they begin to calibrate, guess what happens? Numbness. If parietal lobe is your main problem or main part of your problem, numbness, tingling starts to go away. Sometimes it'll go away pretty rapidly. Sometimes it'll take a long time. It just depends on the individual and their full metabolic situation. So we use activation to get that brain back. And I won't go into all the different activations we use, but basically there's no drugs involved. There's no drugs involved because drugs don't strengthen the parietal lobe or the temporal lobe or the frontal lobe or the cerebellum or anything other parts of your brain, okay? So we might use vibration on you because vibration is a very powerful stimulant to something called the cerebellum, which controls all of the signals that go between the parietal lobe and your feet and back to the parietal lobe. And we might use something as simple, and I'm getting very simple. We might use something as simple as having you put your hand in a bag and try to identify objects, because if you want to strengthen a muscle, what do? You use it. If this part of the brain is the part of the brain that identifies objects, what do? You force it to identify objects. And guess what? If you could take pictures of it, it would look like there were little nuclear blasts going off in your neurons in there. Because here's what happens when you activate the brain. Your neurons, your brain cells, which have become weak, or you wouldn't be here if the parietal lobe is part of your problem, your brain cells, which become weak, can strengthen. The research shows that as you stimulate the correct brain cells, they'll actually get larger, they'll get denser, and they'll create more and more connections from one to the other. Anybody ever hear, anybody ever heard of, the brain's a kind of a funny, you know, it's a new area and a lot of people understand it. Does anybody know what plasticity of the brain is? All right, plasticity of the brain is this. Okay, you used to think that the brain could never change. We now know absolutely for certain you can change it fairly easily, okay, fairly simply. So in other words, if you were starting to play the piano, all right, and you played the piano, you would use your hands a lot. This hand and the amount of neurons that were dedicated to playing the piano would grow. It would, the neurons, the nerve cells that were dedicated to the hand in the first place that you are actually using will then start to connect to other ones around it and recruit them so that you can become more efficient at playing the piano, because your hand would have more nerves and more neurons that are recruiting. That's what happens when you do the stimulants to affect the brain and to get it back. So if you can actually establish new connections, stronger connections, and make this brain go back like this, and then do exercises that keep it that way, guess what? The corrections are, first of all, your pain goes away, and second of all, the corrections are what? They're going to be long-term. They're going to be permanent. And they're going to be something that you can practice and do it at home and things of that nature. So this is how it's done. You need to do a full evaluation and find out which parts of the brain are on fire. Now, there are other little nuances that are involved, but I'm trying to get you the basic idea that your brain patterns can be changed. This is huge for most chronic pain patients, not just the peripheral neuropathy patient. Okay, but in your particular case, those of you who have a parietal lobe problem, this is how it's handled. No drugs, no surgery, but you need to determine which parts of the parietal lobe aren't working. There are other parts that have to work in sync with it. You might have a frontal lobe problem, you might have a cerebellar problem, and they all work together. So if you have one other one that's out of balance with these two guys here, so if you have this one and then this comes down through the cerebellum, but you also have a frontal lobe problem and all three of them are together, you have to correct all three because they're in balance. Okay, so it's a little sophisticated to figure it out, but once you figure it out, the stimulation part is pretty direct. We use a TENS unit maybe on the neck because an electrical TENS unit sub-threshold where you can't feel it, can actually, the electrical side can actually stimulate the cerebellum and the parietal lobe and the frontal lobe depending on how you do it. It's really pretty straightforward. So that's how the brain gets activated. And I mean, there's 100 different ways you can do it. We have vibration that we use on the arm. We also see people, we have our activation part of it. Sometimes we have people standing there like this throwing a ball up because your parietal lobe has everything to do in the world with something called proprioception. Balance. Every joint in your body has a proprioceptive mechanism that's a balance mechanism. And if you do this, you're firing your right parietal lobe off like crazy. And if you can't do this, you need to get to the point where you can do this because that's what will absolutely strengthen. Now, does that make sense? I see I'm trying a new approach here tonight because I'm trying to really draw it so that by the time you walk out of here, you really have a good idea. So here's how it works. Somewhere along the line, for most of you, your brain started to not fire correctly for whatever reason. I've had 6 concussions, so my brain may not be firing all that correctly, okay? And I've done a lot of this work, and it's helped me tremendously. I thought I was getting Alzheimer's 2 years ago. Seriously, I'm not joking. I mean, I was that bad, and I've done a lot of this work on myself. I've done a lot of the nutritional work, and it really has saved me. And so I'm trying to help you to understand this. And so first what usually happens is the brain function goes off. You may or may not have had other metabolic imbalances in your system, like the blood sugar, like an iron problem. You may have had other problems like the autoimmune problem. And those problems create inflammatory responses. You can look this up on the internet, all my internet nutties, okay? Inflammation is where it is at today, and if you look up the inflammation relative to the brain, you will see that this inflammatory process, the gut is like the second brain, the next stop is the brain. So if you have an imbalance, you have a blood sugar issue, you have an autoimmune problem, it drives that imbalance, and it not only stops it from trying to get better, because your body is always trying to get better. It stops it from that and does what? Most of you are getting worse. Some of you are the same, but most, I'd say 95% of the peripheral neuropathy patients that I have evaluated are slowly, gradually getting worse. And that's why. So you have the brain that's dysfunctioning, you have this other situation where the metabolism is making it worse, and then whatever it is that triggered it. Could have been a trauma or whatever. That's how chronic pain works. And specifically if you're dealing with autoimmune thyroids, or if you're dealing with iron problems, if you're dealing with right parietal lobes, you specifically are going to come up with what the diagnosis is that you have been given, which is peripheral neuropathy. So that's what peripheral neuropathy is. How we do it, we take a patient in, and we do a full neurological exam. And I tell you, we do a neurological exam, and I'm not a neurologist, okay? And Dr. Gates is very close to obtaining his chiropractic neurology diplomate. So we have a pretty good background in neurology. In chiropractic college, most people don't know, we actually get more in-class education than the medical guys. We actually get 4,800 hours in chiropractic college. And a lot of it's dedicated to human anatomy and physiology, and I had one of the best neurology teachers in the country at the time, so I was very fortunate that way. So we have the background to be able to do all of this. And we'll do a pretty extensive neurology evaluation. Most people will say they've never been evaluated that way. We take about an hour. We take about an hour and find out what your nervous system looks like. Then what we do is we take the patient in the back and we apply some of these activation stimulations to see, is your nervous system responsive? Now look, if you're really, really sick, if you're someone who smokes, if you're someone who drinks, if you're someone whose diet is absolutely mind-numbingly horrendous, if you have all different types of problems, you're not going to be a great candidate for this. That doesn't X you out, but you're going to have to, you would have to be someone who would want to change. I'm just telling you right now, because I'm going to make those of you who this was important enough to, all of you who felt it was important enough to come out and listen to a seminar on peripheral neuropathy on a Wednesday night when the UNR basketball team is playing. They're just starting, no, they're starting at 8 o'clock. So, but we're going to make a special offer to you. But what we do is we'll do this neurological evaluation, and then we'll go in the back and we'll apply the different stimulants. Different people's brains respond to different stimulations. You're all different, people. Every single one of you is different. Every single one of you takes a different approach. Single one of you takes a different stimulant. Now, the nervous system should be extremely responsive. We are our nervous system. I mean, no matter what you have, no matter what step along the way that you have taken in your advancement as a human being, whether you learned how to walk or move quickly or whatever it was, that was you building more neurons and firing off more neurons and getting a more complete functioning brain. Okay? And so your nervous system should respond very rapidly to the stimulants that we apply. There are people's nervous systems who don't respond to the stimulants that we apply. And if that person doesn't respond in the first couple of days, if we can't make a change in that person's negative neurological findings, that person's not going to respond to the treatment. And it's a hard thing to see, but it does happen. It does happen, and there are people that aren't going to be able to respond. We then figure out whether that patient is a candidate or not. If there's a response to that treatment in the first day or two, we know that that person's going to be a candidate. Then later on, we'll do a metabolic assessment. If this is something, we're going to make you this offer if you want to get evaluated and this is something you want to do, we're going to give you about a 15, 16, 17, 18-page history to fill out. If you don't have the desire to fill this paperwork out, you're not going to have the desire to do what it's going to take for you to get better. Because when you look at this metabolic assessment form, we're going to assess every single system in your body. Every one. And and for people who go through these types of programs, in case you haven't, in case I didn't make this clear, there would be lifestyle changes. You might have to change your blood sugar. You might have to get off of gluten. Anybody ever try to get off of gluten? Anybody ever hear that? Is everybody seeing the gluten-free stuff in the refrigerator? Let me tell you something. You're going to see a lot more of it because it's a big deal. It's not one of these like nutty type of things that is just coming out. We just had a little girl that we're treating for dystonic seizures, and this gal has been looked at by everybody. And this gal, little 11-year-old, and I'm not making fun of her. This is how she was. When she came in the door, she'd been the pediatrician, she'd been everything. We're not doing dystonic seizures. We're doing functional medicine. So by the time they were done with her, we looked at her, and this has a lot to do with you. And we looked at her brain and said she's got a pretty severe dysfunctional imbalance syndrome. She had a high firing, what's called mesencephalon. But she was severely allergic to gluten. She was in here today. This kid's totally normal now. We're talking what, 3 weeks or something like that? They were going to send her to the Oakland Children's Hospital. They're going to do this. She's totally off of gluten. This is an 11-year-old kid, and she was totally normal today. And at first she said, am I going to have to be off of ice cream and for the rest of my life? So we didn't say yes. Today, what did she say?
She said you want to stay off it forever.
She said, I feel better now than I felt before I had the seizures. She says, I have more focus. She says, I have more energy, more clarity. I want to learn. A lot of the autistic kids have this, okay? A lot of you have this. This is the type of thing that you're going to have to confront. This is not a take a pill, get better type of a thing. So there's a two-sided coin to this, okay? The two-sided coin is that most of you can actually get better. Believe it or not, most of you can actually get better. But usually it takes a lifestyle change. We put a lot of time into these cases. We don't accept all cases, and we don't accept any more cases than we can handle, frankly. So we only accept so many of these a month because sometimes it'll take 3, 4, 5 hours of just reviewing all the paperwork and so on and so forth. We will sit down with you and do a neurology exam. We will sit down with you and go through that 18 pages. And again, it takes about an hour. And at that point, we would know, is your metabolism something that looks like it's going to fit your pain pattern, or is it something that looks like it might be just too far gone, frankly? I mean, the first person I ever had that came in that had this, I said, you're drinking a lot. You're drinking like 4 glasses of beer and 4 martinis a night, which means she was probably drinking 6. And you're smoking a pack of cigarettes a day. Would you be willing to at least stop drinking the martini? She said, no. I said, I said, then you're not a candidate. I mean, that blood sugar, martinis, blood sugar, the whole thing, you think that affects your nervous system and all that kind of stuff? So I'm just telling you because when I talked to you about, giving you this opportunity to get evaluated, I just want you to keep that in mind. Don't waste your time if you think that lifestyle changes is something that you would not want to make. Because I have yet to have a peripheral neuropathy patient come in here that hasn't had to make at least some lifestyle changes. How long does it take? What do? We look at the patient and we find out what's wrong with it. If you got a parietal lobe problem, that's it. That's not very hard to fix, frankly, truly. But if you have a parietal lobe problem and you have an autoimmune problem and you have a blood sugar problem and then we got to get you off the cigarettes and we got to get you, guess what? That's going to take some time. Because you're going to have to strip different systems down and have different systems get better. And the good part of this is a lot of people come in with peripheral neuropathy and have 12 other things go away. Why? Because the brain controls everything. So I mean, we've had one older gal that came in here for Alzheimer's, and we do early Alzheimer's, okay? Stage 1 and stage 2. Neurons are sick, neurons aren't working, you strengthen them, you get them cleaned up, trust me. You can come back. And she was so excited one day, she wanted to tell one of my other patients, she said, can I tell that patient that she should do this dizziness and vertigo program, because we do that too. And she said, and I want to tell you, the biggest thing that I had happen was my incontinence has gone away. I had no idea she even had incontinence. But the point being that once you start balancing out the nervous system, the nerves are controlling a lot of different things, and a lot of different things can start happening. So that's how it happens. Does that make sense? Does that make sense? I'm getting a few more heads shaking, yeah. I'm getting a few more heads. I'm really struggling with this because I really thought I was doing a great seminar. I was really it was fantastic. And I started asking my patients, I go, do you really understand what's happening out there? Because patients are getting better. And every one of them went, no, I have no idea what's happening out there. And I went like, what? So I'm changing it tonight. Actually struggling a little teeny bit tonight because I'm trying to draw a little bit clearer picture of it. And I hope we're doing that. So that's how it happens. We look at your nervous system, we figure out what part of your brain is the problem, and we go at it, and we stimulate it, and it will improve, okay? It will improve. If we accept you as a patient, I'm going to tell you right now, you're going to improve or get better. If we don't accept somebody as a patient unless we expect at least a 75 to 100% improvement. And that's our goal, and we can do it. And then we look at your metabolic forms, and then we'll put together nutritional programs. We'll sit down with you for another half an hour, 45 minutes, or an hour, whatever it takes, and say, this is how you got to eat. This is what you got to stop eating. This is how many times a day you got to eat. You got to add this to your diet. You get to get this out of that. You might have to take these specific supplements. We use a very specific line because we know it works, okay? That's what we do. How long it takes depends on how many systems you have involved. And the more systems you have involved, generally, the longer it takes. The less systems you have involved. We've had some people that we just gave them supplements. We've had some people that we just did the neurology. We've had some people that we had to spend a year with because we had to strip one system down at a time, at a time, at a time. No two of you are the same. Every one of you are special. Every one of you are different. That's kind of what makes it interesting to do, because this is not a cookbook deal. So that's what peripheral neuropathy is. There's a lot more imbalances that can be involved, but the ones I spoke about tonight probably are the vast majority of what the research shows and what we have found to be true in correcting these types of problems. So that's what peripheral neuropathy is. That's how you get it. That's why one size doesn't fit all. That's why the medications don't fix it, but they can dampen it, but they can't fix it. That's why the surgeries frequently aren't successful, because it just doesn't fit into that one size, take a pill, do a surgery model. So here's what I would say to you. Most of you can get better, not all of you. Most of you can get better, for sure. Don't think that you can't. And if you don't buy what I'm saying tonight, don't stop trying. Find somebody else that you do buy it from, because the body was made to get better. You just have to find the right keys. That's one of the things that the book says, is it tells you why and how you can get better.